what do you want to do? What is, so hepatorenal syndrome, is it more of a pre-renal type or intrarenal or obstructive? What is it? It's pre-renal. It's decreased perfusion to your kidney, and as a result, you're going to end up with AKI, right? So when you suspect hepatorenal syndrome, what are you going to do?
Not go.
Remove all the diuretics.
Take all the diuretics off, number one, okay? You will stop diuretics. And again, in order for you to say the patient's got hepatorenal syndrome, what should your creatinine do? Your creatinine should typically rise by
50%.
0.3 in 48 hours, okay? Or creatinine should rise by greater than 1.5 times patient's creatinine, right? If that happens, then you will call it AKI, right? And apart from that, you will also get urine studies, okay? In your urine studies, what would it look like? It would look like pre-renal, okay? Low sodium state, right? So it'll be phenol is going to be low. And also you're going to have a bland sediment urine, okay? Bland sediment urine is what you're going to look for. When all of that's present, you're like, okay, there is concern for hepatorenal syndrome. Now, is this a diagnosis of exclusion? Yes, it is. You want to make sure the patient does not have anything else that's going on that's leading to the nephrotoxicity. Not on VAC, not on some other drugs or any of those things, right? Stop diuretics, number one. Very good. What's next?
Challenge with albumin.
Very good. You're going to challenge with albumin. How much albumin?
100.
So it's 1 gram per kilogram of body weight per 24 hours to a max of 100 milligrams. Okay, and you'll give it for how many days? 2 days, right? You will give it for.
It used to be 3.
Oh, it's now 2.
Yeah. You will give it for 2 days, and you will see if the patient responds. Okay, so the albumin challenge becomes very important. Okay, what else do we have to give them?
Midodrine, if they're fine, oral sterilic, we can't leave it.
So that's the thing. Very important point you just brought up, right? So for the longest time, what we've been doing is we were always, if it was hepatorenal syndrome type 1, right, it was always albumin, and the other 2 drugs we always speak about is octreotide, right? Octreotide, why? To drop your portal pressures, and then we speak about midodrine, which is a tablet pressor, right, to raise the blood pressure so you perfuse the kidneys. But if it's hepatorenal syndrome type 2, you typically needed a vasopressor, which is going to be given as Levophed. But right now, your first line is in fact telepressin. It is not norepinephrine. Telepressin is your first line. In fact, we do have it in the US. So that is your treatment. Now, when would you give somebody SBP prophylaxis?
History of SBP.
If somebody's got SBP in the past, sometime you will do lifelong prophylaxis in this patient, and typically you'll keep them on like a ciprofloxacin or a levofloxacin, something like that, right? When else? GI bleed. If somebody's got a GI bleed, you'll start them on SBP prophylaxis. Do they have to have ascites? You will do SBP prophylaxis in a liver cirrhotic when they have any form of GI bleed, even in the absence of ascites. That's very important. Okay. So prophylaxis we give ceftriaxone, but you can use 1 gram. How many days you do this for?
3 to 5.
It used to be 7 days. Now it is 5. They have decreased the duration. It is now 5 days, no longer 7 days. Yes. I mean, you can switch. You don't have to be on ceftriaxone. Duration is 5 days. You'll start, and you can always switch the antibiotic to Cipro or any other drug that you want to, but 5 days is the duration. Okay? Alright. What else can liver cirrhosis lead to?
But you know how in prophylaxis there's also like the creatinine, the BUN, the albumin less than.
So, when somebody's got SBP, the question is, when should the patient get albumin? That's the question. But on the context of SBP, say we diagnose somebody with SBP today, right? If somebody gets SBP, you're getting an infection, right? When you get an infection, you will become hypotensive. When you become hypotensive, you will develop hepatorenal syndrome. So the whole point is to still prevent hepatorenal syndrome. So there are certain criteria. If met, you will give them albumin. What is the criteria? Number 1 is you need to have your ascitic albumin. Ascitic albumin needs to be less than 1.5. That's the first important point. Okay. After that, you're going to need creatinine greater than 1, BUN greater than 30, and a bilirubin greater than 4. Okay? If you had these parameters together on the context of SPP, then you'll give the patient albumin. Why? To prevent hepatorenal syndrome from happening. No, if somebody's got a GI bleed, always think about it. When you're bleeding and you're vomiting blood, you're also swallowing blood. Blood is a lot of protein. You digest the protein to produce ammonia. So whenever you have a GI bleed, you will develop hyperammonemia. So a GI bleed will actually lead to hepatic encephalopathy. So you'll treat hepatic encephalolactulose first and then rifaximin later to see. Okay, so the next important thing you need to know is if somebody's got ascites, right, with liver cirrhosis, how do you manage them chronically, right? So when you manage them chronically, what drug do we need to put these patients on? Spironolactone. Why? So why do you want spironolactone? Because it's all to do with, if you understand the normal physiology, everything makes sense. We said albumin is low, oncotic pressure is low, you're going to activate RAS. When you activate RAS, you get angiotensin 2, which is going to stimulate aldosterone. And what is aldosterone going to do? Reabsorb sodium and water. And that sodium and water is what's making you fluid overloaded. So your drug of choice to solve the problem is to block aldosterone. That's why you'll start them on spironolactone first. Your main drug on the context of liver cirrhosis is actually spironolactone. What is the role of furosemide here? Now that we've spoken about all the problems that liver cirrhosis can do, let's just go back to the causes a little bit here and try to dial out a few things that the boards like to ask. If somebody is drinking alcohol and they come to the hospital right now with acute abdominal pain, they're jaundiced and their liver function numbers are going up, what should you think about?
Alcoholic hepatitis.
You would think about a condition known as alcoholic hepatitis. Now, when you're thinking of alcoholic hepatitis, what is important? What would your AST and ALT be?
ALT twice the ALT.
So AST and ALT, AST and ALT, what range, what numbers will it be? Is it thousands? It's not thousands. It'll be around 200 to 300 range. Okay? That's important. So it won't be the thousands, but it'll be 200 to 300 range. And your AST to ALT ratio should be greater than 2 is to 1, right? So that ratio is what's going to tell you that the patient's got alcoholic hepatitis. Just because somebody's got alcoholic hepatitis does not mean they get steroids. So what determines if they're going to get steroids? You're going to do something known as your Madri's discriminant function or your MELD score. Okay? Your Madri's discriminant function needs to be greater than 32 and your MELD score needs to be greater than 20. If you have Madri's discriminant function greater than 32 and a MELD greater than 20, meaning the patient's going to have a poor prognosis, those are the patients you'll treat with steroids. What is your steroid of choice? Huh?
This one?
It is prednisolone and not prednisone.
Oh, yeah.
You have to give prednisolone and not prednisone. Why? Because prednisone needs to get converted by your liver to prednisolone to actually act. Steroids. Another important thing, when somebody's got liver cirrhosis, the boards is also going to ask you a couple of very important things is make sure they get all the vaccines.
Yes.
Okay, all the hepatitis vaccines they need to get, COVID vaccine they need to get, although COVID might be a controversial topic at this point, and influenza vaccine, pneumococcal vaccine, all those vaccines. Yes, they can develop osteodystrophy because of liver cirrhosis, so osteoporosis screenings you'll do, and most of them you'll start them on bisphosphonates if it is the case. When patients have liver cirrhosis, they should be very cautious about eating seafood. Okay? Why?
Oh, Vibrio.
Yes, you have Vibrio